Okay. And I am recording this class. I assume that the other person on here must be Charity, so I'm going to assume that she's attending because I see one other person. She'd be about the only one. So the zombie assignment really has a lot to do with the effect of drugs on the CNS. And if we look at that, as portrayed in movies with the usual Hollywood lack of exactitude in their so-called science, I don't believe they're possible. However, there can be stages at which people take on a zombie-like behavior. And as I said, there is a natural product that induces this kind of state. So I want you to be looking that up and preparing something in class. Now, I don't know how this is going to work with Charity, but I propose that it's a small group and you all work together on it. So for about the last half hour tonight, I want you guys to work together on working out how to do this project. So what is it? Where does it come from? How does it work? Etc. The instructions are there. How much is needed? How long does it last? Is there an antidote? And how can it be administered? You'll make a presentation in class next week, and everybody will participate to the extent they can. Don't worry, you'll write up a report to present and then give to me after you do the presentation. It does not have to be APA format. However, it should be well written and grammar and everything ought to be observed. As for your presentation, you can do it a lot of different ways. You can even do a little skit if you want.
All right, that escalated quickly. Okay. He's so done with your shit.
All right. Anyway, Charity, if you didn't hear that, Layla just informed Emily that's going to bury her. No burials. No burials.
Okay.
In this state, you have to embalm people to bury them anyway. So that wouldn't work. The thing I'd like you to do is consider how to do this. The presentation can be serious or it can be fun, but it actually needs to have some information. Take it seriously. People that do skits for Viet Lab are very serious about the work. So think very carefully about this. But I would like you to work together since there are in this room there are only the four. We'll try and figure out how to integrate Charity into it. You guys can be in communication with her and get her input. But the point of the idea of the project really is to look at an active natural product that has profound CNS effects. Okay, so we'll talk about that. So, any questions? All right. Now, good evening. All right. Enough silliness about zombies. Let's talk about the CNS. I'm going to hand you. There are 4 different handouts here. So, and on Wednesday, we'll be talking about pain.
something you'll get to deal with, about which there's a lot of information now. Pardon? There are 3 handouts, 4 copies of each. Okay. All right. So let's see, pull up. All right, so I have this PowerPoint that is in your that's in the shell. I'm going to run through this thing relatively quickly since we don't have quite as much time as we did this morning. I did post this morning's class, by the way. So the human nervous system is, you remember from your A&P, there are 2 basic components, the central system and the peripheral system. The central nervous system comprises the brain and spinal column, and is really the heart, if you will, and controller system of the nervous system in general. However, parts of the nervous system function fairly independently, and in fact, there are parts of it that don't even necessarily directly communicate with the brain. The peripheral nervous system is what comes off the nerves that come off the vertebrae. They link these nerves link the CNS, the central nervous system, with all other parts of the body, including the sense organs. As you know, the sense organs merely gather information and create signals to the brain, which actually does the work of including what that information is, including our eyes, our ears, touch, etc. All of those go through the CNS. The peripheral system also includes the autonomic system, which we talked a little about last week in cardiovascular. The autonomic system is what controls the various organs. It's an involuntary system, which is not to say we have no control over it. We can hold our breath for a few minutes and then pass out if we hold it long enough, and then we start breathing, because that's what the body does. We don't generally have a lot of, okay. All right, Charity, I'll try and stay right in front of my computer and see if that actually helps with, yeah, trying to, I'm not sure exactly where the mic input is on this computer. It's not directly up front. Is this a little better if I sit right in front of the computer? Okay. All right. So we'll go from there. All right. So I'm not going to move around as I sometimes do in front of the computer. So the involuntary system is composed of the sympathetic and parasympathetic. The sympathetic is our fight or flight nervous system, and the parasympathetic can be called rest and digest. The sympathetic system leads to bronchodilation, vasodilation, and the parasympathetic goes the other way, constriction and of both the bronchial system and the basal system, among other things. And then we finally have, also as part of the peripheral system, the somatic system. This is the voluntary system. This is what allows us to tell our arms and legs to do what we want them to. And we do that with conscious and usually with volition, even though at times it seems automatic.
such as when we're just walking down the street, we automatically put one foot in front of the other. We don't think about it, but it's still the voluntary system that's running that process. All right. So we have the nervous system involves using molecules known as neurotransmitters to take information from one neuron to the next. The neurotransmitters in these various systems are somewhat different. The neurotransmitter in the parasympathetic arm of the autonomic system is acetylcholine. In the sympathetic arm of the autonomic system, it is norepinephrine and epinephrine and adrenaline. Okay, so we use those neurotransmitters to activate sequentially nerves and put a signal down a nerve pathway to actually affect some action in the body. Other neurotransmitters are glutamate, which goes to the pleasure center of the brain, gamma aminobutyric acid, known as GABA, which is an inhibitory neurotransmitter. It helps regulate and clean up some of the others. And dopamine, which is used throughout the brain, as well as serotonin and a couple of others. So we have a little graphic here on slide 12 of the show and the handout that gives you an idea of what these various neurotransmitters actually affect, the kinds of effects on the brain. For instance, if you have very high levels of dopamine, these are associated with schizophrenia. And I'm very careful here to use the word associated. Proof is not necessarily available for all of these. That's just, we can see that the symptomology, other symptoms of the disease can be, or the condition, are associated with these levels. Anxiety is just the opposite, very, very low levels of dopamine. Excuse me. Happiness is regulated or associated with serotonin. Depression with high levels of serotonin, rather. Happiness is high levels of serotonin. Depression is associated with low levels of dopamine and serotonin. The various feelings we interpret as love are associated with high levels of serotonin, dopamine, and another transmitter, oxytocin. And then the fight or flight syndrome usually involves, again, it's the sympathetic system, and if you remember or the parasympathetic system, and if you remember the main neurotransmitters are norepinephrine and epinephrine. So fight or flight, that kind of excited, anxious in whatever phase that we have, high levels of norepinephrine and epinephrine, very high levels. So various diseases, pathologies that are associated with the CNS, stroke, which is a physical issue rather than, or at least a physical cause rather than associated with chemicals. We've got seizure diseases, various seizure disorders, Parkinson's, Alzheimer's, the various motor neuron diseases, such as multiple sclerosis and amyotrophic lateral sclerosis, Lou Gehrig's disease. Depression, anxiety, bipolar disease, psychotic episodes associated with schizophrenia, and we'll talk a little about the hyperactivity disorders. Stroke occurs when the brain is damaged due to a cardiovascular, a vascular incident of some sort. There are two major causes of stroke, types of stroke. One is an occlusive stroke, occlusive, meaning an artery in the brain is blocked, and therefore the tissue downstream from that artery gets starved of oxygen and dies. There are two kinds of those. One can be atherosclerotic. You can have a buildup of sclerotic lesions in the brain arteries, and another is caused by a thrombus, a blockage that occurs because something gets loose in the blood and blocks off an artery. Fine, and the other form is what we call a hemorrhagic stroke. It's when a blood vessel in the brain actually bursts and blood is forced into brain tissue. And blood, for all its wonders and importance, is very, very destructive of our brains. There's also what we call mini strokes, transient ischemic attacks, or TIAs. And these can be either thrombotic or atherosclerotic. And they basically are very much a reduction of the ability of the brain to get oxygen. Usually they're temporary. What happens is something will cut off a little, an area of the brain from blood flow, and you'll see some stroke-like manifestation, but it could be as mild as foot drop, which is not going to be seen by most people unless they know what they're looking at. They also tend to be very temporary. You have a TIA, and then you get better. And a lot of times people don't even know it. When the last time we spent any real time with my father, when he was still mobile, he was having TIAs, and my wife and I could see it, but my sister and brother-in-law could not. And what we saw was foot drop. When he picked up a foot, I think his left foot, to put it out, most of us, when we pick up our foot, our toes will come up as well. Well, if someone's having foot drop, when they pick up their foot, their toe goes down. And so they flop the foot down. Well, we could see that. It was pretty clear. But as I said, my brother-in-law and sister did not know what they were seeing, and therefore they missed it totally. We had to talk to them about it. And they usually come and go. He had at least 3 incidents over 4 days that we saw. So they come and they go, and then he's better, and that's common. Is it possible for them to lead to other things? Well, yeah, I suppose, but they generally clear up, and they generally clear up because the body clears out whatever the blockage is. So when we have an ischemic stroke, in other words, an obstruction, either atherosclerotic or a thrombus that blocks off blood flow, we deprive an area of blood and oxygen, and in very short order, the brain tissue begins to die. In a hemorrhagic stroke, a blood vessel actually bursts. And by bursts, I mean develops a hole in it. The hole can be small, or it can be pretty major. But what happens then is blood will pump into the brain, and at that point, it starts destroying brain tissue. Often it is pumped into, if it's a big enough stroke, it can destroy enough brain to be fatal fairly quickly. If not, these are the strokes that leave people completely debilitated, as opposed to the occlusive strokes. Usually don't do that much. So what we have, if you see a person having, and you think they have a stroke, you take a close look at them. We have this thing called FAST. which is FAST stands for face, arms, speech, and time. So what happens when a person has a stroke? As you know, the right side of the brain controls the left side of the body and vice versa. So you can tell by looking at them what happens there. If they have a stroke, you look at their face. They may have something, and they may not be able to speak very well because only one side of their mouth is going to work, right? So you can't, they're very blurred in their speech. So you can see the slumping. That's the speech part and the face part. The arms, if you ask a person, if you think they're having a problem, ask them to raise their arms. If they raise their arms and they're doing fine on both sides, then that's probably not the issue. But if they get their arms up and one of them starts doing one of these, then there potentially is an issue there. And then the speech, and then this is where the time comes in. The faster you can get someone to the hospital, the better. If we can initiate treatment on a stroke victim within half an hour, they have a reasonable chance of recovery. If it goes up to about 3 hours, we're being fairly successful. After that, it gets real dicey as to whether we can do much for them. Now, it used to be thought that you have a stroke, your brain's dead, or that part of the brain is gone. Forget it, it never recovers. Lately, we have been learning much more about the brain. There have been several books and a whole lot of research published about something that we can call, in general, the plastic brain, meaning the brain can repair itself. It's not real fast to grow new cells, but they do grow. The thing is, the brain can be taught to reroute signals and to learn to control the body. Because what happens with the stroke is usually one half. You can almost take a line right down the middle of a person's body and see one side is working and the other isn't. And it's all the way from working some to not working at all. And so this is called hemiplegia. That's how we differentiate this kind of paralysis from spinal cord injuries, which are paraplegia or quadriplegia, meaning both legs or both legs and both arms. You're not going to get just both arms. But the issue with, and that usually involves a spinal cord injury. But with a stroke, that's strictly the brain. Although we can have brain stem strokes as well. Those are usually pretty nasty. But the issue is to get them to the hospital fast. Now, if we can get them started, and there are techniques that we can use. Unfortunately, our medical system hasn't embraced them as well as it should. But there are approaches to therapy that you can use that can actually train people to recover most, if not essentially all, of their functionality after a stroke, depending on how bad the stroke is, or a head injury resulting in the same kinds of damage. Years ago, my wife had a patient who came to her. She's, as you know, she's a physical therapist. She's also trained in something called the Feldenkrais method, which is a body education method that's based on physics and engineering principles. And it's basically PT on steroids. This guy came to us. He'd had a head injury resulting in stroke-like symptoms and a mix of stroke-like and paraplegic symptoms in his case. But he came to us with barely able to move. He'd had an accident parasailing. And he had this accident, and he came basically unable to move. His personality had changed, which happens a lot with head injuries, by the way. That's another CNS issue as well. But his personality had changed. It was destroying his marriage and wrecking his relationship with his very young children. His wife was desperate, found Susan, brought her husband, and she started working with him. And as I say, when we first saw him, he was
barely able to move. He needed assistance going up and down stairs. He was a young man. He was probably no more than 35. So way too young to be taken out of functional adulthood. So Susan worked on him, and it took a while. He was very severely involved. But a year later, he was jogging behind the baby carriage, something he never thought he'd ever do. And then Susan kept seeing him for a while, and then we left North Carolina and moved out here to Colorado. And about a year after we moved out here, we got a phone call from his wife, and she said, we're going to come visit you. And they rode up on their motorcycles. Now, David was driving a three-wheeler, but still, motorcycle after a major head injury, pretty amazing. And it's because Susan helped his brain learn to reprogram itself, to reroute all the signals, and to train his body to function. And it's really, so these things don't have to be as debilitating as they are, but the medical profession and the medical system isn't ready to move in that direction yet. Treatment, if we can get them into the hospital with this is for an occlusive stroke only, atherosclerotic or thrombotic stroke only. We can use clot busters, TPA or streptokinase or even urokinase to help reduce and dissolve the thrombus. If we have patients that we're worried about a risk of stroke, we can treat them ahead of time with anticoagulants or with antiplatelet drugs, platelet adhesion inhibitors like aspirin, or even if you really wanted to go further, Plavix, clopidogrel, works for that. This doesn't work after a stroke. They don't help in the slightest after a stroke, but they can help prevent this kind of an incident. The most common anticoagulant, of course, is warfarin, Coumadin, which is also known as rat poison, because that's what it is. But it works by inhibiting vitamin K-dependent clotting factors. It also is something we've been using for a century. Rat poison, yeah, warfarin. Yeah, it started off as a rat poison, in much higher doses than we give it to humans, fortunately. But it works by interfering with the clotting factors, and then a minor injury and they bleed out. So that's how they work. That's what I want to say about stroke. Let's go on to seizure disorders. Seizures are something that occur as a result of abnormal electrical activity in the brain. In other words, a lot of it is hyperactivity of neurons. We really don't know why most seizure events occur. There are a few. There are head injuries. Seizures associated with head injuries are not uncommon. Seizures associated with high fevers. We know what causes those. High fevers, very high temperatures. Other than that, it's still an area where there's a whole lot of missing information because we just can't seem to find it. It's a complex issue. Seizures can be intermittent or they can be recurrent. And when they're recurrent, we refer to it as epilepsy. Okay? Epilepsy has all the same kinds of seizures as any other seizure, except that it's something that is with people all the time. You can have up to a couple of hundred seizures a day in a severe epileptic. You can imagine that this impairs their ability to function. As I say, we don't really know why. There are lots of different kinds of seizures. There are what we call the tonic-clonic generalized seizure. This is where they have people shaking and contracting and quivering and bouncing and so forth. What you see in a movie that depicting a seizure, because the rest of the seizures are kind of boring. These are exciting. They're also very exciting to have to deal with as an outsider. We have partial seizures. These really only occur in certain areas of the brain, and they don't necessarily go on for very long. We have absence seizures, in which the person just isn't there. They're sitting, they're not responding to anything in their environment. You can go run your hands across their eyes. They don't know you're there. It really, all of us can get there sometimes, and it's not always a seizure. I guarantee you there are times if I'm really concentrating on something, I might not know you're right in my face, but I'm not having a seizure. I'm just deliberately withdrawn from, the physical world for a few minutes. And then there's an emergency situation called status epilepticus, which has to be treated immediately and lead to death. How do we handle seizures? Well, first off, the first thing with a seizure victim is to make sure they don't hurt themselves. You want to be sure they have nothing in their mouths that they can suck into their airways, because that's a good way for them to suffocate. The other, people talk about, they're going to swallow their tongue. Well, that's not physiologically possible. So,
like, I know now that you're not supposed to, but when we were being told it in school, because we had a girl,
yeah.
we were told we needed to get tongue depressor and put it in her mouth to prevent her from biting.
Well, that's a possibility. It's not necessarily a big issue. Besides, one tongue depressor, she's got teeth on both sides. I'm not sure that's all that helpful, but could be. Yeah, well, but the object there is don't put your hand in her mouth, because that's what people try to do. They try to reach in and maybe get things out. Bad idea. That might get you bit. And human bites are not safe. Anyway, the best thing you can do is get all obstacles out of the way, help them gently get to the floor, get a pillow under their head. Generally speaking, they have an autonomic response that often presents as chills. And so I usually wrap them in a blanket. I've had 2 students down in Denver who had seizures in my classes. One of them, bless another student's heart. I just really appreciated this. She was the mother of 6, and 2 of her children had seizure disorders, and she knew what to do. She was a blessing. Oh yeah, it's very scary. I've seen it actually twice at school, but I've seen it 2 or 3 other times as well. Well, yeah, you're the first time you see it, you freeze. What am I supposed to do? But when you see something like that, your first thing is get them to the floor. You don't want them falling and hitting their heads. So get them to the floor. Get anything you can out of the way. Furniture, everything. We were throwing desks across the room in the lab. Just whatever we had to do to clear the area. And then we had some pillows. We were right next to our CNA lab. So we went and grabbed a bunch of pillows and blankets, and then we called 911, because that's all you can do. Do your best. Yeah, do your best. Yeah. If you have someone, are you talking about a really, really heavy patient or furniture? Yeah. Well, yeah, you just protect them. Yeah, there are things you can't move. Like you can't, if the guy's next to a wall, you can't move a wall. Yeah, if you can move them gently away from any object they might hit, you should.
was one of our teachers that wanted to test it.
Yeah,
And when she fell, what we did was we put ourselves
yeah,
so that she wouldn't,
yeah.
because that was
That's,
all we could do.
yeah, that's all you can do. There's nothing you can do of a first aid measure. Except usually what happens is these things are short-lived. In both the cases that I dealt with, within a couple of minutes, they were starting to come back around and they had no idea what had happened. You know, why am I on the floor? You know,
A girl in the class who has seizures literally every day that we had class. And my instructor, who was a football coach and everything, he like yelled at us to move everything. So like we would move the chairs, he'd get her to the floor, we'd call the nurses station, like we would run to the nurses station to get help and everything.
yeah,
And as bad as it sounds, she even had a seizure in the morgue. We went to the morgue for accident thing, and yeah, she had a seizure.
that could have been set off by,
We thought it was stress induced.
well, it might be, but it could also have been set off by the various chemicals in the morgue.
Yeah,
Yeah, could have.
so yeah, like
Yeah. That's hard. So, but anyway, that's how you deal with it. And then get them comfortable, get them safe, and call help because you need to get them to the hospital. Pardon?
it's really hard.
Yeah,
the first time.
that's really hard the first time. You sort of freeze. You know, what do I do? What do I do? What do I do? Well, you know, if you have been, you know, been given some instruction and know, okay, what do I do first? Get them safely on the floor. And then worry about the furniture.
Like, I still almost- we had the teacher stop the first time she had a seizure. Just got up and started pushing desks.
Yep.
Two of us went over to her and were like making sure she was situated and not in the while the rest of us were moving desk and the teacher's sitting there.
Yeah, right.
What is going on?
What are you doing?
It's like, she's having a seizure. Go on about your business. And I've got my phone and I'm.
She's
going,
having a seizure. Go get the nurse. Get out of here.
911. Like,
Let the experts deal with
we're
it.
good. You just keep doing what you're doing. Well, we all
Yeah.
got in trouble. We didn't inform the teacher that it was possible. And then
That's
we
not your
just, like,
job.
Well, but then we just like took over the classroom. So we got in trouble for obstruction of authority or whatever. And we're just like, okay, we'll take the detention.
Yeah, right.
Did you see the teacher? She stood there the entire time. Even as the ambulance came, even as the people
Yeah.
came in, she just stood there.
Right.
Sorry.
Yeah, right. Do you want somebody who knows what they're doing or do you want to give in to authority? I know what my answer is.
Well, and it's like for all of us, we were so used to it because all through middle school and elementary school, it was like she would have a seizure and we would just, the teacher would continue talking and all of us would get moving and the teacher would sit down with her and that's what we would do.
Yep.
And we just kept that through.
Yeah, well, you know, the problem was that the parents should have told the school, and they probably did. The school should have told the teacher, and they probably didn't. You know, there is a case of, you know, there are certain things that, even though we have this thing called FERPA now, there are certain things that teachers have a need to know. And there's no coverage, there's no restriction on that. So,
Well, it's like,
especially if everybody else in the class knew it, so.
yeah, well, it's like my nephew's teacher. And it's like, he's a severe asthmatic. Yes, he needs an inhaler. Why has nobody told you this?
Mhm.
Why did we have to tell you?
Yeah, well, that is part of the problem. Anyway, we have lots of different drugs that can be used. The problem is it's all guesswork because since we don't know what are the causes of most seizures, we also don't know how to treat them well. So there are a number of them. What happens usually is we'll start with some of the ones that have been around for a long time. Dilantin, also known as phenytoin, has been around since, probably 100 years now. And it has a lot of side effects, but again, like a lot of drugs that are old with side effects, we understand it real well. In reality, seizures are best dealt with by a neurological specialist in seizure disorders, because most general practitioners, although they will see seizure patients, since we seem to have a surprising number of people who have seizure disorders, I find, they're not trained other than very generally. And so we really need to encourage people to see specialists when they have such diseases. There are lots of different drugs, and Dilantin, as I say, has been around for about 100 years or more. It has other activities, and it can cause a lot of problems. But we also want to remember that these drugs that we've had a lot of experience with, we understand them pretty well. A lot of people don't like it, but it is very effective in some patients. In fact, all of these drugs are effective in some patients. There are patients that don't respond to any drugs. One of my students down in Denver was an epileptic. I never saw her have a seizure, but no drugs worked on her. So she had a seizure dog, a dog that would tell her when she was about to have a seizure, and she would lie down. And then she'd have her seizure, and then she'd get up. And so that was useful. A number of different drugs. There are new drugs. The newest drug out is Keppra, or Keppra rather, and it is. There are people who really like that drug, and then there is everybody else who absolutely hate it because of its side effects. It's very debilitating. A lot of times, seizure patients will be patients with epilepsy will be on a cocktail of drugs, because we're trying to mess around with brain activity. Remember, the definition of a seizure is abnormal brain activity, and that can be for a lot of causes. So there are often we will see patients on a number of them. There's lots of slides about these things in this PowerPoint with side effects and so forth. You probably want to review it. It is a rather, it's not as long as the cardiovascular slideshow, but has a lot of information. Another disease that we deal with in the CNS is Parkinson's. Parkinson's has been recognized for about 2 centuries. It was first described a couple of centuries ago. It can occur in middle age and even somewhat younger, but it's primarily a disease of the elderly. There's no cure, and the causes are still a bit on the obscure side. Characterized by abnormal movements, and especially it's characterized by tremors that you see. You see it first in the hands, and an inability to stand straight. Now, a lot of people don't stand straight. Why? We sit here like this in front of our computer all day long, and pretty soon we get locked in, right? Which is one of the reasons I'm acquiring a standing desk, so that I can actually have something that I can stand straight to look at my computer instead of sitting hunched in a chair.
I just have to pulling my shoulder back.
Oh, whiplash injury.
Well, I still have moments like I'll be hunched over something and somebody will walk behind me and I'll snap back because I don't want that.
Anyway,
It works.
yeah. They often have difficulty with coordination. They have, yes, Emily. Well, that's different.
I'm pretty sure that's just an argument.
And what we have seen, however, is that there are decreased levels of the neurotransmitter dopamine, and there's an imbalance between acetylcholine and dopamine in the CNS. Again, we don't know why. We can correlate this, and it's a good diagnostic, but the other part of it is, as you've seen Parkinson's patients, as the disease progresses, they become their gait pattern changes and they become shuffling, a little like the zombies, shuffling along, and they have often will have dramatic swings in mood. Now, I want to say we're going through a list of diseases. We're not going to cover every possible CNS disease. There are many of them, and some are characterized by mixed sets of symptoms and signs. But there are many more. Parkinson's is, there are some brain changes, but of course you can't see much of this until you do an autopsy. So what we do is we try to look at dopamine and acetylcholine levels and balance them. Now, can we cure Parkinson's? No, that doesn't happen. However, we can try to limit the progression and signs of the disease. But we use a lot of drugs that are dopamine analogs or generate dopamine, and we use anticholinergic drugs to lower acetylcholine levels. The most common drug and the most effective is levodopa, which is a form of dopamine. And it is almost always given in combination with carbidopa, which actually potentiates. Remember the term potentiation from discussion of pharmacokinetics and pharmacology, where one drug greatly enhances the activity of the other without changing its own activity. Well, carbidopa is a good example of a potentiator because it potentiates the action of levodopa such that we can cut the dose as much as 80% to get the effect. And the reason we want to do that is that levodopa has some side effects that we don't particularly like, including over time loss of effectiveness. We develop a tolerance to it. There are also some issues of mental confusion, which, of course, if you've got Parkinson's, you don't want confusion on top of that, although sometimes they do go hand in hand. And sometimes hallucinations. So it's a kind of agent that sits for a while. It's stored in the brain, and it stays in the brain until it's needed. So what you cannot do is simply quit taking it. You need to be weaned from it if you're going to be taken off on it. So there are some drugs that are dopamine mimics. They imitate dopamine in the brain, and there are
a number of those. They too, as all drugs, have a lot of side effects. So we still prefer to use levodopa, carbidopa combinations. The next thing I'm going to talk about briefly is Alzheimer's disease, which is a progressive degeneration of the nerve cells in the brain, losing, and results ultimately in loss of memory, thinking ability, language skills, and can lead to behavioral changes, altogether too often violent behavior. What happens is the neurons which are involved in this die off because they break connections with other cells and become isolated, and then they simply die off. No known cause. Lots of theories. And the only way we can diagnose it accurately is autopsy. So when you hear someone say, oh, he has Alzheimer's, you might want to question that, because there's no way to know other than an educated guess based on the symptom complex, the signs and symptoms. And you also need to know that it's not a normal part of aging. In other words, it's not something we expect. Now, again, can we expect it? Yep. And if we expect it, are we more likely to develop it? Well, this turns out to be true. People who have Alzheimer's running in their family and are convinced that they're going to develop Alzheimer's seem to do so at an alarming rate. And that kind of decision making basically helps prepare the way. Now, maybe they would have anyway, but nonetheless, my view is that even if you have it in the family, just tell yourself, well, I'm not going there. And if you really believe that, good chance you won't. It is, however, a very common thing to be seen. And it does change the brain. That's why we can definitively diagnose at the time of autopsy. But it does affect the brain. Does affect structures within the brain. We get protein plaques building up inside the cells, and then these tangles and other twisted fibers outside the crenellations of the brain. It just looks weird. Dementia is something, as a generalized term, is something that occurs when you lose the ability to think. You start losing memories, but it's not usually associated with the behavioral changes that are seen in Alzheimer's patients, or the age of onset for other dimensions is usually later. Okay. My 98-year-old mother-in-law and 100-year-old father both have some dementia. They're forgetting things. They have forgotten things that used to be very important to them. My father can barely remember my niece and is convinced that she is his great grandchild, when her children are his great grandchildren. And he doesn't even remember meeting her children, because basically, my father was very important to her when she was young, and she came up to Northern Virginia to have her children baptized in my dad's church that she used to go to as well. And he doesn't remember any of that. And these kids are
8, 9 years old now. So anyway, it's time to take a break. Let's take 15 minutes. And then we'll come back to continuing to talk about Alzheimer's disease. And I'll mention something that's not a part of this at all. So Charity will be back in a few minutes, so 15 or so. Make it about 7:15 by my computer. Okay?
I turned in my well, I turned it in on campus.
Okay. This afternoon?
Yeah, that's right before class.
Oh, okay. That's why I didn't see it. Okay.
I don't think it's gonna be 10 minutes. It might end up being more.
That's all right. I hope not 20.
No, it just, there's so many drugs that count as, I'm gonna say antihistamines because they're part of it, but that's not what it is. Anti-asthmatics. There's.
Yeah, there are. There are. And there's
And I
more
don't like
every
any
year.
of them.
Yeah. There are more every year.
Well, I'm like, just looking at some of them, I'm sitting there going, why? Like, I understand not breathing versus having severe nausea. I'll take the severe nausea, but it's like,
Because some people only respond to those drugs. Every individual has the potential to be very different. Some people respond to none. Yeah. Yeah.
it was like shocking as I was going through it and finding like all the drug combinations and how one person with asthma can end up on like 7 different medications just to treat the asthma. That's not
Yeah.
even counting all the other shit that they might have on. It's just the asthma.
Yep.
And then like finding out that most of them aren't diabetic compatible, which with Charity in the class is something I think about a lot with this stuff.
Yeah.
But finding out that like if she was asthmatic, she almost couldn't take any of the drugs.
There would have to be some very special approaches made to dealing with that. But yeah.
Like most of the albuterols.
Yeah.
She couldn't take any.
Right. Yeah. Interferes with insulin.
Yeah, about the only thing she can take is the antihistamines, and there's even a couple of those that they're like probably shouldn't.
Yeah.
Like we don't know for sure, but probably shouldn't.
Yeah. When in doubt, no.
Right?
Pues tengo lo que terminé y lo pongo en unas públicas a 3 minutos para hacerlo. Y no voy a responder como 8 preguntas.
But like, he has actually broken a bone before, but he treated the sprained wrist like he's shattered his arm. And it's just like, calm yourself. I can say that my sprained ankle hurt much worse than Max's broken ankle. Well, yeah, because it's a constant. Yeah, it's a constant. Broken one went away. Yeah. But yeah, the entire time he was in a brace. And like he acted like he was dying. And it's like, oh my God. And then he was sitting there expecting to be babied, and it's like, you have a sprained wrist. You're fine. You're gonna live. I promise. Well, yes, Mom, can you feed me? No, you have a sprained wrist. You can use your other hand to use your utensil. We'll cut your meal up for you. But you can. Unless you're like my little sister and broke both her arms. Well, yeah, then of course we feed it. I mean, that's significant. That's significant, but he sprained his wrist. Kids these days. I'm not feeding you. You can eat. You are 11. Seriously. It's like you can use your other hand. I understand writing is going to be a little hard, but you can use your other hand.
Practice. It's good to be able to use your left hand to write. You never know when your right hand isn't going to be functional.
I can decently write. Don't ask me to sign my name, it won't happen, but I can decently.
These days, what do you need to sign your name for?
I went back to school. I was in like middle school. And I had a pillow with me that I had to carry around with, like, shove it into my broken arm and like walk around with it and have it on the table. It was the most uncomfortable thing ever.
Yeah, I bet.
Like I was out of school for like 6 weeks.
Aye.
Go to school and going to school and then going to doctor's appointments. A shorter task because I broke this arm in half. So it was not fun.
That sounds painful.
Yeah, my arm, the x-ray, it was like this. And then
Oh my.
my hand. It was bad.
Yeah.
I've never broken a bone, and I'm glad to have never broken a bone.
Mm-hmm.
Because I don't have the patience for that nonsense.
Yep.
Try breaking ribs.
Oh, no, you don't want ribs.
I have cracked ribs.
Okay, let's go ahead and get started. Treatments for Alzheimer's. Again, we have some drugs that can potentially improve cognitive ability. There's an awful lot of claims out there that you can reduce the likelihood of Alzheimer's if you use your brain a lot, play intellectual games, that require cognitive thinking, crosswords, Sudoku, those sorts of things. Pardon?
Or you can get a book. That happened with my
Oh, well,
We got her just a like little word game.
yeah,
You know, fill in the letters, not even like a crossword or anything.
Yeah.
She got mad at it, and I was the one who had given it to her, so she threw it at my head because she's like, it's
well,
like,
but you know, once you start having these dementias, it may be a little too late. I don't know that that's ever been proven to work. Um, and if you look at one of the most famous of the Alzheimer's patients in recent years, Terry Pratchett, who author of the Discworld series and other sorts of things, a very facile, clever mind, always thinking. He had Alzheimer's. So, you know, does that work? I haven't a clue. Um, am I doing what I can to make sure that I keep my brain active? You betcha. I don't know if it'll work or not. It might. Well, it won't hurt. That's for sure.
well, that was also flip from the audio side. The other one they suggested to us for women was baby dolls. Give them a baby doll to take care of.
Yeah. Well, yeah. If they drop it, it won't get hurt. But there's, you know, what can you do? Well, you know, we try. What can be done is there's a whole lot of work been done pharmaceutically and things we call cerebral enhancers, basically trying to speed up the brain. Don't know that they've had much success either. So there are sort of behavioral management methods that have been developed to help people deal with it. But the fact is, if you can't think and you've lost your memory and blah, 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 what do you think you're going to learn? I mean, there's all sorts of jokes about, you know, you meet a new set of friends every day, and, you know, these are not very kind things to say, but in reality, that's they have no short-term memory. But tell you a story. This happened in a nursing home, a high-level nursing home, someplace. I'm not sure exactly where, but they used to have performances every Saturday night in the nursing home. And there was one woman who would always show up. She always came in dressed to the hilt. She never said a word to a soul, and just would show up and be there. And then one day they had a concert pianist come in, and he started playing the melody line from an aria of an opera. And this woman got up, went to the piano, sang it perfectly, and sat down. She'd been an opera singer. That was her career. And that was apparently her favorite piece to sing. She remembered it. And if you get a person with dementia and get them talking about, play music, if they respond to music, get them to sing their favorite songs. They might not talk to you otherwise, but if you can get them started singing, it'll just pop out. Because certain parts of their brains are working perfectly well. Their long-term memory still was there, even if they've lost the ability to recognize faces and place faces and names. But they will remember things from their past quite a bit. So you can deal with it, but it's not easy to do so. I said I was going to talk about something. There is a disease, a horrible disease that actually has we've had some experience in our family. It's called Lewy body disease, and the symptomology is a mix of Alzheimer's and Parkinson's, and it is routinely a 7-year course of disease from diagnosis to death. And we've had 2 family members, one of whom was my wife's uncle, the other of whom was
what we think of as she was definitely a family member, but she was the wife of a second cousin. So no biological relationship whatsoever to us. But she had it, and she was diagnosed in her mid-40s. It's what Robin Williams had. That's why he committed suicide. He knew enough about the disease to know that he did not want to go through it because it gets progressively worse, and occasionally people start getting violent with it. It just gets worse, and it's characterized not by tangles and all that stuff, but by little nodules called Lewy bodies, and Lewy, Lewy, was the guy who identified it. But it's a nasty disease. There are no treatments. All you can do is try to help control some of the symptomology. But they lose contact with reality. They're wandering off. They become incontinent, impossible to take care of. My wife's uncle, who had it, it doesn't matter how smart you are. He was the dean of the vet school at Davis in California, and he had a PhD as well. So he was no schlock when it came to the brains department. And so it has no relationship to anything except that it appears. And we're starting to see it, or perhaps we're starting to recognize it much, much more. But there isn't anything we can do about it. And it is, unlike Alzheimer's, which is not a deadly disease. Lewy body is fatal. It's just you can practically count the days from diagnosis. It's 7 years. Yeah. And that's why, as I say, that's why Robin Williams committed suicide. He probably, being a smart man, he may have been diagnosed with it and then gone and looked it up and said, ain't doing this. And so he committed suicide. So anyway, neurodegenerative diseases like multiple sclerosis or Lou Gehrig's disease, amyotrophic lateral sclerosis, which is the disease that Stephen Hawking had. Normally speaking, these diseases will hit people in their 20s to 40s. MS seems to hit women more. ALS seems to hit men more, for whatever that's worth. And what happens is that the protective barrier, the myelin sheath around the axons breaks down, and so then you get these plaques called they sclerose, they get hard, and then the nerves are affected. When the sheath keeps the nerves from being stimulated by the surroundings, and the loss of that sheath is very, very unpleasant. And those lesions, and these lesions also appear in the brain as we start seeing it progress. ALS, at least, usually has a fairly, if you're diagnosed with it, usually in your 20s, you're not expected to last more than about 5 years. Stephen Hawking lasted 50, actually 55, from his diagnosis to his death. Very unusual case of the disease. Yeah, just a minute. I'm just sending a quick note to Charity. Okay. So again, we have some treatments that can help prolong, help make patients more comfortable and dealing with it. We have a few drugs that can modify the disease. It's a disease of exacerbations and remissions. Sometimes we call them flares or relapses.
or whatever, but the disease gets worse and then it gets a little bit better, then it gets worse again, and it keeps going through this cycle. And so you'll see people that have MS, and one day they'll look very, very bad, and the next day they'll look normal. Not usually on that short a notice, but if you see them a week later, they may look fine. So, and people can live a lot longer with these diseases than they used to, but there aren't any cures. What happens is a lot of times the demyelinization will lead to things like nerve firings, muscle spasms, and so forth. So one of the treatments we use is an antispasmodic drug. ALS, Lou Gehrig's disease, is essentially the same thing as in MS. We have a few drugs that actually seem to slow the progression of ALS, but those are still in clinical trials. There's no guarantee they'll ever be out there and in use. We'll have to see what happens, but there's no way to cure the disease. And again, cause is what is the question here. We don't know why. So I'm going to talk next about drugs for psychological and emotional disorders. We'll call it that: depression, anxiety, schizophrenia, bipolar, and the hyperactivity disorders. Depression is one of the most common psychiatric disorders in the United States. It is probably more commonly diagnosed than it should be. Clinical depression shows itself in certain signs: withdrawal, excessive sleep, thoughts of suicide, and general lack of interest in life, giving up activities that you were once very fond of doing, all sorts of things. Decreased energy and fatigue are part of it. It can make other health problems seem worse. In fact, treating depression successfully has been correlated with improving comorbidities, coexisting illnesses as well, simply because when we're depressed, they just feel like they're worse, especially things that are related to things like chronic pain and so forth, and things like PTSD, a component of which actually is depression. These chemicals that treat the depression don't really affect the disease directly. But if your attitude toward your disease changes, you deal with it better. And the symptoms, your particular symptoms, seem to reduce. So depression is kind of nasty. As I say, I think it's probably overprescribed with sometimes devastating effects. I'm thinking of an incident that we're aware of where a man in his mid-30s who was very close to his mother, she died suddenly, and he got naturally depressed. Everybody gets that. I mean, you're going to be sad. You lose someone that close to you that suddenly. And so the doctors gave him about 2 weeks to recover and then stuck him on antidepressant meds. And then he started drinking, and then he started taking drugs, and that was the end of that. Ultimately, he ended up divorced. He's not even allowed to see his kids. And I blame the doctors. Grief takes a year. There is a reason the Jews don't put up a tombstone until a year after the death of a family member. And that's because grieving is a process. And sticking people on drugs just hides it. And it doesn't do anything for the problem. I honestly believe that no one should be treated for depression without concomitant counseling from competent, trained psychiatric professionals. Unfortunately, again, our medical system won't support that, and yet it would have such a positive effect. But that's being too logical. Again, depression, we don't really understand depression. We know it's associated with an imbalance of serotonin and norepinephrine. Is that the cause, or is that something else? We don't know, to be honest. It is a theory still. We just don't know. We have a lot. The way this works, and what we're talking about, we talked about depression being a severe lack of serotonin and norepi. And what we're talking about is a lack of drugs in the interneuronal space. Okay. When we have too much of these drugs in the neuronal space or inside the neurons, because what happens is a neuron fires and it emits either norepi or serotonin, or maybe both, and they cross that interneuronal gap and attach to a receptor on the next neuron, stimulating that neuron. And then that neuron absorbs the norepi and or serotonin in order to use it again, to recycle it for the next firing. If we block that, it seems to have an effect on, positive effect on depression. Okay, it relieves some of the symptomology. So that's why we say we block the uptake. We use a lot of drugs. The problem with drugs active in the CNS is all of them take a while to take effect. You don't just swallow a pill and 30 minutes later you're fine. Not like taking an ibuprofen. It does take time. It may take up to 8 weeks. So this is one of the reasons that depression is hard to treat chemically, because again, we're guessing at what to give the patient for their disease. And so we give the patient a drug. We know it's going to take anywhere from 2 to 30 weeks to show an effect. And then, since they all have a long half-life, we have to give them a fair amount of time to wash out. So getting a patient onto an effective drug regimen for depression can be a lengthy process. Very frustrating to the patient, very frustrating to the family, and it leads to non-compliance. So it's very difficult. You have to have a patient this is why I think we need counseling as well, because you need to have someone standing by the patient saying, yeah, you're actually doing much better. I'm seeing some changes, even if they're slight, to keep them on course. Yeah.
She got told that she had depression.
Mm-hmm.
Okay, how do we fix this? And it was just a doctor in the neonatal unit. This was after she had me. And he had noticed it during her pregnancy with me, but hadn't said anything because she couldn't take anything while she was pregnant with me.
Right.
And then after she was pregnant with me, it got chopped up to
Postpartum depression.
Postpartum depression.
Yeah.
And then it continued far longer after the, at that time, expected end date for postpartum. And I mean, she still has it, but they never sent her to counseling or anything like that. So when the drugs didn't work after a week, she's like, not taking them. And she never went back.
And she never gave them a chance because they never told her that it was going to take that long.
And then,
And part of the reason they don't do that is they expect that there be a high level of people who simply would throw them away.
but then recently with my siblings and all of that, they've had counseling, just life and all that. And the family counselor got her in touch with I think it's a psychiatrist, not a therapist. And
Therapists can't prescribe drugs. If you want a drug prescription, it has to be a psychiatrist, an MD, which
Yeah.
psychiatrists are MDs.
so she got her in touch with a psychiatrist, and the psychiatrist, the family counselor, and then my younger sibling, husband, she stayed on her regimen. And I've noticed the changes, even though because of how far away she lives, we can only talk on the phone. I've noticed the changes like over the phone and all of that. So, I mean, it's a huge difference, but it took all of this nonsense to get her to stick with her regimen.
Yeah.
And it's like ridiculous that it took all of that, but they never gave her that as a new mom.
Yeah.
It's like, she's got a baby. You might want to think about, I don't know, checking up on her.
Well,
They
yeah.
never did.
And who knows? I mean, doctors are, have different attitudes about these things, and they're very busy, and it's not surprising. Of recent years, we've gone to the more the tricyclic antidepressants, which were the drugs that came out in the 50s and 60s and were very successful at treating, they were used a lot, I should say, for treating depression, are non-selective. They will block the reuptake of norepi and serotonin. So the appearance of the selective serotonin reuptake inhibitors, the SSRIs, really gave a different way of approaching that imbalance between acetylcholine, or between norepi and dopamine. And so they have now become first-line drugs. Now, severe depression, you still should probably use a tricyclic antidepressant, a non-selective uptake inhibitor. These drugs have really nasty side effects in some ways. But this is the family that includes Prozac and Paxil and Zoloft and so forth. They are some of the largest sellers we have. They're very large sellers in the pharmaceutical industry. We also have the selective norepinephrine reuptake inhibitors, or SNRIs. They basically they call them selective norepi, but they actually end up blocking the reuptake of both. They're also known as dual uptake inhibitors. Again, this takes some time. Drugs like Effexor and Cymbalta are examples of this class. The neurotransmitters themselves are important for other purposes. So, just blocking them completely is not a good idea necessarily. There is, again, the psychiatrists who specialize in these things. Again, I honestly believe that none of these should be prescribed by a general practitioner. I think that if you think a patient has a depressive disorder of some sort or any of these, they should be sent to a specialist. It can be an MD who's a specialist, not a psychiatrist per se, but an MD. But
A psychiatrist, that's their world. Last resort therapy is an old group of drugs, the monoamine oxidase inhibitors. The problem is that these things affect a number of different neurotransmitters, because all of these neurotransmitters are monoamine transmitters. So what that means is that they chemically are susceptible to monoamine oxidase. And oxidase metabolizes, changes them, and moves things around for these drugs chemically. To inhibit that is to change the amount of drug or the amount of these neurotransmitters that are in the system. They've gotten a bad rap. They have some nasty side effects, things like you can't eat cheese or certain cheeses if you're taking these. Also, they do not play well with other antidepressants. It's a very dangerous mix. So they're last line therapy. These drugs have been around for often ages. And again, they are drugs that are slow to build up and slow to wash out. So we want to be careful with that.
If they block serotonin, dopamine, and all of that, does that mean if they're blocking all of that, does that mean there's no emotions in the person? Or?
No, it doesn't. What it means is that they really suppress a lot of nervous activity. They change the way it works. People still have emotions. People still have feelings, and they don't work on everybody either, just like anything else. But yeah, that's not the issue with them. The issue is that they have so many side effects, and they're too general. Lately, we've been looking for drugs that are much more specific in their activity. A drug that you've probably all heard about is Wellbutrin or bupropion. It's what we call an atypical antidepressant, in that it doesn't fall into any of the other classes. It does work on dopamine, but it doesn't fit into any other class that we have. It also, in one form, as Zyban, is a smoking cessation agent. The antidepressants have black box warnings. The warnings are a couple of things. If you mix some of these drugs with drugs for treating migraine, you could have something called serotonin syndrome, which is a potentially fatal syndrome that causes hallucinations, agitation, high temperature, blood pressure fluctuations, sometimes extreme. It's very, very dangerous. There are a number of drugs that have that. Another part of these black box warning is that many of these drugs also, they're supposed to treat depression, but they actually cause, especially in children and adolescents, an alarming degree of suicidal thoughts. I know of at least 3 instances here in Colorado of people who have committed suicide on these drugs. So it's really not good. Bipolar disorder is something we see a lot of. Again, we used to call it manic depressive. Bipolar is something that's characterized by real swings in mood and activity. You'll go from being, the manic phase, you're delightful, you're funny, people want to be around you, and in the depressant phase, you're walking around under a black cloud, and it can be pretty extreme. We have long cycle bipolars and short cycle bipolars. Long cycle bipolars can be manic for months and then depressive for months. Short cycle bipolars can be manic 5 minutes and then depressive in 5 minutes. It can be that extreme. There's no way, and it can vary. One day you might be running on a short cycle, and then you might be a couple of weeks in each phase. So it all, what does it? I don't know. But what happens is people cycle like this, and it's very um, it's very it's very difficult to deal with. Um, they also tend to be temperamental when they're in the manic phase. They tend to have an uncontrolled temper. Um, they will engage in amazing behaviors, some very destructive. Um, it's really difficult to deal with someone who's dealing in the manic phase. On the depressive phase, on the other hand, they dive into the black pit. Um, they are they show all of the symptoms of major depressive disorder, um, and so they cycle back and forth. So our drugs need to lower the highs and raise the lows to try and get people into something in the middle. And therein lies the problem. Too many bipolars won't take their drugs because even though they hate the lows, they love the highs. They're addicted to them. So they stop taking the drugs. When you have someone who's on bipolar treatment, you need to really work with them and make sure that they are taking their drugs. And here again, they need counseling. So we use mood stabilizers. A series of mood stabilizers include things like lithium, which we have no idea how it works, but it does work.
You don't know how it works, but it works.
It does. It does relieve it does stabilize the moods. I have some thoughts as to how it might be working, but there's no data that can back it up that I've run into. Sometimes anticonvulsant drugs can be used as mood stabilizers. Lithium, all of them have different side effects. Antipsychotic drugs can be used. This includes things like Zyprexa and Abilify and some major drugs. Haldol, which has been around a long time. Haldol has been around for 60 years about. So we do have a lot of these drugs. They all have their, obviously, issues. Sometimes we use antidepressants to treat it because, of course, there's a depressive phase. But if we do that, we need to give them some other drugs, the mood stabilizers or antipsychotics along with, because the manic phase almost acts like a psychotic phase. So you don't want an antidepressant drug by itself, because antidepressants have no effect on the manic phase. Schizophrenia, pardon? The new word for ADHD.
Oh, no.
That is the new term for ADHD these days.
Had, like, going through this,
yeah.
Where she was super high, and then she would get into these dark phases. Like, there was nothing we could do to raise her out of them. Remotely. Which, I mean, she had a lot of other problems too, but yeah, she got diagnosed with that. You can't give any of those drugs to a child, can you?
They do. You really want to watch something that'll open your eyes? Go to pbs.org, look for Frontline Special, The Medicated Child. I show it in a lot of my classes, and I get mad every time I see it. I just want to strangle those damn doctors. They have no business treating kids that way. And none of them are properly trained. My opinion. Sorry. You can imagine I don't like it when I see things that are actually doing more harm for kids than good.
Well, and I don't came up with treatment once they received the diagnosis. Her mom and my mom talked, and then we never heard.
Yep.
And she never really got better or worse. It just, we learned to deal with it. So,
Mm-hmm. Schizophrenia is characterized by agitation, hallucinations, delusions, all sorts of things. Withdrawal, schizophrenia is often appears in people in their late teens, early 20s, and it's a lifetime disease. We treat them with drugs, and they sort of reach a balance, but they're never really again functional in society. So there are some drugs we have for those. Anxiety disorders, including things like OCD, PTSD, panic, what we call generalized anxiety disorder, etc. We often use antidepressant drugs of some sort. There are some anxiety medications like the benzodiazepines that were developed for treating panic and anxiety. Unfortunately, they tend to be something you build up a tolerance to, and therefore you can't use forever. Sometimes beta blockers can be used because anxiety often is associated with increases in blood pressure, and so we try to reduce those symptoms. Again, we're treating symptoms. We have sleep disturbances are something that people get to deal with. We have drugs for some of that. Some of the benzodiazepines have sedative or hypnotic dose activity at high doses. Then we have Ambien and Lunesta, each of which has, what I've heard from people is that people who have tried both prefer Lunesta because it works for them. They actually get some sleep. They can actually sleep for a while. Sleep is really something that is a physiological function that should be well guarded. Sleep disorders can be treated with some drugs, but what you really want to do is try diet modification, exercise, meditation and yoga. These actually will help sleep in many people much more than drugs will. Also, we have this habit in our society of snacking late at night. Bad idea. Bad idea. Shouldn't eat anything at least several hours before you go to bed. I mean, drink water, yeah, but eat a bunch of carbohydrates, eat a bag of potato chips, a bunch of popcorn, whatever, while you're watching a late night movie on TV, bad idea. The attention deficit family of diseases, hyperactivity, attention deficit disorder, attention deficit hyperactivity disorder, way overdiagnosed, and treated with, we call them stimulants, because what they do is what are the outward signs of ADHD? Well, you can't concentrate on whatever you're doing. I have seen some kids that really did need to have drugs. Rarely. I've seen other kids that are they're just being kids, and give them something to do. I used to tell people, what do I do? My kid was diagnosed with ADHD. Get him a dog. Get him a dog. Let him run the dog. The heck with the drugs. Don't do the drugs. Because they wanted to put him on Ritalin or Adderall, and I have no faith in those drugs, especially in kids. Now, having said that, methylphenidate, Ritalin, and Adderall can be used to treat narcolepsy very successfully, but it's different doses, and it's usually narcolepsy in adults. So we have a variety of drugs. They're all stimulants. Most of them are Schedule II controlled substances because they're also very addictive. I mean, they're amphetamines and amphetamine-like molecules. The stimulants actually have a use for as I said, a use for narcolepsy. They modify activity in certain areas of the brain. But again, we're talking about different doses here and for a different purpose. Lots of side effects. If you watch that medicated child video, which I sort of suggest you do, there's a whole segment on there about ADHD medications. We are allowing kindergarten teachers now to tell us that we have kids with ADHD. And yeah, and none of them were qualified to make that diagnosis.
Oh, no. And my mom told them flat out, you're talking about the child that's sick, but find out once. Yeah, she's got ADHD.
Yeah. Yeah, and the problem is that that once you get labeled that way in the schools, you're stuck because it follows you through your schooling, especially if you stay. If you don't, unless you move every time the rent man comes, you're going to stay pretty much in the same school, and it's going to follow you through that school.
Yeah, and I was every year, all the way into high school. In high school, my mom sat down and said, "Go ahead, get a specialist.
Yeah.
You're paying for it. Get a specialist. Prove to me my child is ADHD, and I'll put her on meds."
Yeah, and they couldn't.
No.
Of course not.
The specialist gave me the little test thing that they do, and she's like, "There's not a marker anywhere."
Yeah.
Like everybody has like she had me focused on stuff, and I could stay focused on each task she wanted me to do.
Yeah.
And I did them with direction and everything she wanted.
Yeah.
I didn't have a marker because I was told to do this. It's like,
Yeah.
all right, why? Just do it.
Yeah. If I'll tell you an example of a kid with, I firmly believe, ADHD and needed intervention. Charlie was in a school. It was when my daughter was in, I think, 4th grade. He was one of the students in the classroom, and they took him down to the computer lab that was available to the 4th graders, and they just wanted them to write a paragraph on what they did in the summer. And all these kids knew how to use computers. Most of them had computers at home. Charlie would sit down at his computer, and then he'd get up and go talk to somebody. "What are you writing about?" And then go back to his computer, and then go somebody else. "What are you writing?" Go back to his computer, finally turn it on, then get up and, "What are you doing?" And running around the room. Never got his job done. Never. Could not focus for more than about 5 seconds on anything. And he was that way about everything. He was one who needed help. Now, from what I think I saw of his home life, the whole family needed help. But nonetheless, he needed something. But there is a drug approved back about 10, 15 years ago that's not a stimulant. However, I would, if I had a kid that was diagnosed with ADHD and they wanted to put him on this drug, I'd say no, because it induces these kids and adolescents to have suicidal thoughts. It's the last thing you want. Okay. Yeah. That's one way of doing it.
Well, the
Um,
doctors, she asked about the drugs and they said, well, they're stimulants. And she's like,
Well,
So
so is
like
caffeine,
caffeine.
yeah,
and they're like, well, yes, but this is a different kind of,
Yeah.
so like caffeine.
yeah. So, yeah, for some people, it's been successful. My wife has a cousin who, as a child, was put onto ADHD medication, and it was a big help to him. It was a big help to him. He now has about 6 college degrees, so nothing wrong with his intelligence, and that's probably his biggest problem. He was too smart. So anyway, it's 8 o'clock. I want you guys to get together and work on the zombie thing. Charity, do you want to participate in this? And maybe you can turn on your microphone and talk with the rest of the students about this, or do you want to do something different? Even do it on your own. Okay, here's the chat. Okay, so the yes is do it on your own, or join, or have me turn this around and you can turn on your microphone and talk to your classmates. Join the classmates. All right. So go ahead and turn your microphone on. I think you can do that and talk. So try that. And I will turn on my speaker so we can actually hear you.
You there?
Yep, I am. All right.
Okay.
So, okay, I'm going to turn the computer around so that other people can talk to you as well, and you guys start working on this project, okay? And I'll move the
Yeah.
computer over next to Layla. All right. Somebody want to talk? He can hear you?
Hi.
Hello.
All right. So I will leave you guys. I'll be here, but I'm going to let you guys work on this together. If you have any questions, please ask. Yep.
So are we picking like our sections?
We can do it that way. I don't know, do you guys want to do it by sections? And then. Very much something that I can think of us doing it as a group.
Yeah.
And then just,
Everybody pick something and go for it.
yeah, and then email it all to one person and they can mush it all into a paper and then go from there. We just have to remember to cite our sources.
You have to present this, right?
Yeah.
When? Thursday or Monday? I mean, Wednesday or Monday?
Actually, I was just thinking of the question. I was thinking that we might have a mini presentation, either Monday, if you guys are ready, or Wednesday, just before class. Okay, let's still shoot for Monday. Since Charity can probably be here on Monday.
So. How do we want to break this up?
So how are we doing this, guys?
Yeah.
Did you miss all of that? Charity? Charity?
Yeah.
We're gonna split it up by parts and then we're gonna email it to one person and that person's just gonna basically smush it all together into a paper
Okay.
and then we'll go from there.
Okay,
Um,
sounds good.
So now it's just a matter of picking which sections we all want to do.
So how many groups are there? Are there 2 or 3 or?
No, it's just the one. We're doing it all together.
Okay.
Um,
Have you seen that new drug that came out?
7 times. Which one?
There's this drug that people are taking and they basically go into
Oh, bath salts.
Mm.
Yeah, we did that one. We were watching videos on that one.
I'll do
But
4 and 5.
6 and 7. And I guess that leaves 1, 2, and 3 for us.
I'll do 3, I guess.
3. Do you want 2 or 1, Em? Well, fine. Make me make choices.
Wait, there's 5 of us, right?
Yeah.
So how are we gonna do this?
Well,
Yeah.
yeah. 6 and 7 are kind of a pair. Perla?
Yeah.
Okay. Perla wants to do 6 and 7 since they go
Okay.
together. So we can essentially split up 1, 2, 3. 1 and 2 kind of go together as well. No, that's the thing. They all kind of go together. So it makes this hard.
Now considering there's only 5, it's not an even amount as far as the group goes.
No, there's not. Huh? Yeah, 2 of us are going to have to do 2 no matter how we look at it. Otherwise, somebody would have to do 3.
I'll do 4 and 5 then.
Okay. Chemical or geographical? Mwahaha.
I really don't care. I'm not gonna.
I can put it all together. It's no problem. I have the most time out of everybody, I think. I'm a stay-at-home mom, so. Oh, okay. I'm sorry, I just assume everybody else works, so. I'll do number 2 if you want to do number 1. Okay. I made a decision.
So we sending everything to, like, we're sending the answers to you?
Yeah, and then I'll compile them into a paper. Make sure to send me your source
Okay.
that you use.
Sounds good.
I can't use Prezi. It keeps telling me that I need money to. How do we do a group PowerPoint?
Just realized I don't.
We don't.
I asked Sophia to do a PowerPoint and said we didn't have to.
You don't have, for the zombie assignment, you don't have to do a PowerPoint. You're going to do your presentation and then give me the report.
So we have to have a report either way.
You have to have a report, but
Okay.
you don't have to do a PowerPoint.
Okay. Yeah, so it's just the report. So
So
If
I
you
guess
do-
when we present it in class, I guess we're gonna be reading off, I guess, our sections or,
yeah, and then I'll just hand Mike the completed thing. That way it's all in one place.
that sounds good.
Um,
I was really gonna try to make it into class tonight, but my blood sugar's been going low all day, so I didn't think it was gonna be safe to come to school.
no, that's a stay-at-home situation. Well, what I found. Where is it? Because Mike kind of gave us a hint when he was talking about it earlier. He was saying that the natural substance we're looking at is from the Caribbean originally, and that you see it a lot in hoodoo and voodoo. Which I know what he's talking about. I just can't think of the name of the drug at this point.
There's a New York City outbreak too.
Yeah, that's from synthetic marijuana. But see, that's not natural, that's synthetic. And
True.
in the description, it says there is a natural product that induces a state that very closely resembles what we see portrayed in zombie movies, comics, and stories. And that's the problem with the bath salts or with the synthetic weed, is that they're not natural. They're man-made chemicals that are causing this. I did a little bit of research earlier, and there is mad cow disease and then what they're calling zombie deer disease that cause, yeah, sounds funny, but it's really not. But it, both of those cause the wasting that we see in zombies, but not so much the cannibalistic side to them, or even the brain dead side. They just slowly kind of waste away and die.
Yeah, I just found that when you were talking about the mad cow disease on Popular Science.
Yeah, and I mean, it has stages of aggression and stuff as well, but that's also only in animals. Whereas the voodoo zombie, which is okay. It actually is a horrible Netflix movie. That's the sad part. But this is actually caused by some kind of mix or powder or something, I think it was saying. And it causes them to appear dead and then makes them completely controllable.
And this was in the Caribbean?
The Caribbean, some of it was seen in Louisiana. It follows wherever there's hoodoo and voodoo. Most strongly right now, we see it in Haiti. Just because that's where the practices have.
It says in Haiti, it's 17th and 18th centuries.
Yeah, but voodoo and hoodoo practices still stay up today. They're still used today. only now they're a little bit different than they used to be. Just because they've gotten influenced by Western society. A lot of it greatly by the Catholic Church.
Okay. How much is needed to cause the zombie effect? I gotta find that. So if we do the voodoo, if it's caused by voodoo, I mean,
Well,
that's gonna be so hard to put how much is needed to cause the zombie effect.
not necessarily. It's actually a powder, sort of like a
Sugarcane.
herbal medicine sort of thing that's given to them. Voodoo and hoodoo is just the practice that it comes from. It's sort of the religious belief magic that it comes from. It's also where we get things like red brick dust will protect you from those who want to harm you and other beliefs like that.
That's the powder is called netrodetoxin. Tetrodetoxin, I think.
I'm not sure.
It says it's found in puffer fish.
Yeah, that's a neurotoxin. The tropotoxin.
But that's not the one you're talking about, is it?
Yeah. Am I doing one or two?
One. No, I think we're looking for the stuff that's made from a tree. Yeah, this is the problem with having all of my stuff, is that I don't have my food. Oh, there it is. Are you talking about the host? on the inside. Used to be. Okay. No, sorry. It comes from a flower, right? There it is. Good. Yeah. Okay. Scaffolding? 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 Is that what you said? Yeah, because that was kind of coming up from like Caribbean puffer fish. It's like a natural
Who wants to know how to make it? What are the
frog and human. And they give it to them. And then they die and they bury you and then go and dig them up.
You're not dead.
No, but they're completely out of their minds. So Charity, you were right.
What?
You were right originally.
Am I all right?
You were right.
About what?
The pufferfish neurotoxin thing.
You just faded. I didn't hear everything you said.
The pufferfish neurotoxin,
Uh-huh.
you were right. Because that's the only one that comes out of the Caribbean.
Okay, so I'll find something on that.
The other one comes out of like.
I was researching it more on different stuff. Because they're saying a horse tranquilizer gives like same kind of effects, just you don't like you don't start like your body doesn't start deteriorating or anything.
Yeah, well, and the thing is that horse tranquilizers aren't natural. They're synthetic, they're chemical made. They're man-made. He's talking about something that comes from the natural world and is just used, kind of like willow bark.
Yeah.
How people were chewing willow bark to relieve pain and stuff. That's what Mike's looking for. But the stuff I was talking about is called devil's breath. It's
Hannah, stop it. Hey.
more of a truth serum than a zombie. It doesn't kill them or make them appear dead.
Great name, though.
Makes you do whatever you want. It makes them do whatever you want them to do.
What was that name? Because my dog started barking.
Devil's breath. It's I can't remember where it's from now.
It's okay.
Colombia. But it's it essentially makes them do whatever you tell them to do, but without the appearing dead first. But that's what the neurotoxin does, is it makes them appear dead.
I think I found it. It said Columbia.
Well, we're all packing up, Charity.
Okay, I will write this up and I'll send it to you.
Okay. Have a good night.
Thank you. You too.
Okay.
Bye.
Bye.
I saw that when you shared earlier in there. Once I didn't.
Great.
Right?
That's good news.
I figure we're in that kind of class, so.
Yeah,
Mike, look what I found today.
no kidding. Okay. Okay. Then, nope, she's gone. And